Hi, this is Brian Kim. I'm going to share with you case number 183 in the best way to do cataract surgery series. This is a patient who has a very dense lens. I wasn't quite sure if it was an intumescent lens, but it's a white cataract. I wasn't sure if it was intumescent. You'll see how I handle it because it was intumescent. And I didn't realize it was a Catarock until I started going. And so I'm going to show you how I was able to handle this case. Normally I use a needle to puncture the center and decompress the central bag, but I did it a little bit differently, and so you can see how I was able to deal with that and how I'm able to deal with this Catarock. And this patient also did have a posterior plate in context, and despite using terminal chop, you're going to see this posterior adhesion and how I'm able to conquer the posterior plate and posterior adhesions using the scissoring chop technique. So remember, with the posterior plate, you're able to fracture the lens, but not the deep central core. And so the scissoring chop technique allows you to lift that lens piece up, but then get around it, turn the chopper sideways so it's not pointed towards the posterior capsule, and then you can amputate that posterior adhesion. Very simple, very easy, and very direct way to lyse that posterior adhesion when you're dealing with the posterior plate. So you can see this patient has quite a bit of a Bell's reflex. I use a corneal marker, which will help me to center and size a rhexis. And then I make my paracentesis incision first on the right side and then the left side, making sure I'm flat and parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. So again, when you look at it, it doesn't look super milky, but obviously it is a white cataract. Again, difficult to determine the density of the lens as well in these situations because you don't see a whole lot of yellowing here. This is intracameral lidocaine, and then some intracameral epinephrine, and then some air. So look here. This is a telltale sign. I put the air in, and the air is just coming out of the eye. And so I'm like, what's going on here? Did I have like a suprachoroidal or something? But you can see here, I checked the eye because the air just came right out and I was soft. And so I knew it wasn't that kind of situation, but clearly air is not going in. So I'm going straight to the dye, the trypan blue, and I'm just filling the chamber the best I can because the chamber is so shallow. And then I'm pushing some dispersive viscoelastic to fill the chamber, as well as flatten the anterior capsule and coat the corneal endothelium. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then I enter. At this point, I could have gone with the central puncture technique, but what I decided to do was push viscoelastic, especially since this patient has such a strong Bell's reflex. I'm going to puncture the center with my sharp tip Haldi Percars. And then I'm going to push OVD at the same time. And so I'm going to use a viscoelastic technique to deepen the chamber as I do this. And what I'm noticing here is there's quite a bit of milk coming out. So I turn my chopper sideways, and what I'm trying to do is tap down on the lens capsule to encourage that milk to come out some more. And just because of the way the capsule tore here, I'm not getting a good angle. But at the same time, you can see there's quite a bit of milk coming out. And a lot of this is just allowing that milk to come out. I push some more OVD to fill the chamber and push the anterior capsule down. You can see I'm doing this periodically with the teeth closed, with the forceps. I'm trying to pull it towards me a little bit. But you can see the angle is just a little bit off. But now here, as I push, I'm able to grab a flap. I push the OVD to cause that flap to go up. And you can see a lot of milk still coming out, pushing OVD at the same time to keep that anterior capsule down. So again, I'm using a two-handed technique and using the dispersive OVD cannula to push the anterior capsule down at the same time as I'm doing the rhexis. And in this case, luckily, I was able to get away with it. Obviously, there are cases where there's so much pressure that it just splits immediately. Obviously, this wasn't one of those cases. There was a slow egress of lens material, but I was able to get a nice continuous and complete rhexis. So this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally. Of course, there's so much milk, and oftentimes the lens is already loose. As you saw illustrated in this case, the lens spun really, really easily here. Using some irrigation on the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface lens material. And here I decide, okay, I think this is a super dense lens. Not quite sure. Should I just go straight with double chop? You can see my thought process. And then I said, no, let's just switch and do terminal chop. So I switched to sculpt mode. And then I'm going to go ahead and start sculpting. And it was a good idea that I did. And when you start sculpting, if you sense that it's super dense, then that means you need to keep going. If it wasn't that dense, I could have stopped and then gone back to double chop. But once you do the double chop maneuver, essentially you've already done it. And so I think it was better that I went ahead to the terminal chop, because by going and start to sculpt, you get a sense of how dense the lens is in this case, and it is very, very dense. And like I said, you will see aspects of posterior plate in this case. So it is a rather dense lens, a Catarock. I'm very gingerly sculpting in this situation. Again, I don't like to push super hard. I don't make these long excursions as I do it. I'm just kind of tapping and buzzing little by little as I go. You can see here. And once I'm deep enough, I turn bevel down, switch to quadrant removal mode, placing the chopper out to the contralateral equator, fracturing from the terminal side, getting the fracture to propagate from the posterior aspect through and through. By doing it this way, the chop goes all the way across like a cracking fissure, like when you're dealing with like an earthquake, for example. It's like cracking and propagating from one side all the way to the other side. I place the chopper around the right heminucleus, fracturing the lens. Again, the phaco-tip is deep, fracturing the chopper against the phaco-tip. Again, the phaco-tip is acting like a chopping block, but you can see that adhesion. You see it looks like almost like a sharp, jagged piece of glass or something. It's really, really sharp and jagged, and it won't release. And so I'm just trying to crack. Obviously, it's not working, so I go ahead and just perform cross chop on that one quadrant. And once you do that and you have a piece that's eatable here, you just lift that first piece up. And then once I have that, I'm doing the scissoring chop. You can see the chopper sideways, and I'm able to amputate that posterior adhesion with the scissoring chop maneuver. It's so easy, so efficient, and you don't have to struggle with that posterior plate or that posterior adhesion. I'm able to get around it with that chopper, turning the chopper tip sideways so it's not pointed towards the posterior capsule, and then you can amputate it. Very easy, very safe, and easy to see. Again, fracturing that second quadrant again with the cross chop maneuver. You can see again, nice posterior adhesion there still. I get under it with the chopper tip sideways, and fracture that posterior adhesion. Again, another scissoring chop maneuver there. So easy to amputate the posterior adhesions with a scissoring chop maneuver. You can see here, I just get the instruments around the lens piece, and I just carefully just kind of push, and I'm just crushing that posterior adhesion between the instruments. You saw that illustrated very well with that last piece. So now that first heminucleus is completely gone now. Again, pretty dense lens. Most of the CDE was used with the sculpting. I turn that second heminucleus in front of me, placing the chopper around the lens, keeping that phaco-tip deep in the bag, fracturing the lens in half, placing the chopper around that third quadrant, hooking the peripheral lens, pulling it centered toward the phaco-tip, and then fracturing that lens piece. Such an elegant way to disassemble the lens. Using mechanical forces is just so easy, and it's just intuitive, and it makes sense, you know? You don't have to go after it with high vacuum or ultrasonic energy. I really think when you're utilizing those aspects of the phaco machine, things can happen, you know? You can get a wound burn in particular. You never get wound burns with this technique, ever. You just don't, because you're so ginger with the ultrasonic energy use. You can't have one of those, oopsies, oh, I got a wound burn. and then you have to deal with that whole mess. Because you're using pulses of ultrasonic energy and vacuum, and you're utilizing more mechanical fracturing forces, the issue is just much, much less. So you saw I put some more dispersive OVD to coat the corneal endothelium, and now I'm going after those lens pieces, again, very carefully and gingerly. You can see I'm just kind of tapping, fracturing the lens piece, and then emulsifying the lens pieces. Again, using the instruments to crush the lens, using some vacuum to hold the lens, and then getting around it with a chopper, crushing the lens between the instruments, and then emulsifying the lens pieces. The last piece of that third quadrant, getting the chopper around the lens piece, crushing it between the instruments, using some vacuum to hold the lens piece. Again, holding it with some vacuum to just kind of get it into position, and then crushing the lens between the instruments. So you can use a little bit of vacuum, especially in this context, because there's basically nothing to protect the posterior capsule. You can use some vacuum to position the lens piece on your tip and then crush it between the instruments. So this is, again, a really dense lens, intumescent lens. Luckily, didn't get an Argentinian flag, but really a big whopper of a lens piece. This is really a Catarock. No posterior capsule protect you. This is from center to edge, a dense lens piece. Again, get the chopper around the lens, performing a cross chop maneuver here. Separating the lens piece, getting the chopper around that fragment, using the vacuum to hold it for a second. And then crushing the lens between the instruments. So you can see here, there's no epinucleus or cortex material. There's nothing to protect the posterior capsule here. Some people would do like an IOL scaffold technique or something like along those lines, but I'm just very carefully using sparing amounts of ultrasonic energy and vacuum, and just crushing the lens between the instruments, and then keeping that chopper deep. And I don't know if you notice this, I always make sure that when I'm emulsifying the lens piece, that I have a existing lens piece that I'm not emulsifying still in the bag, just underneath me. And so that's intentional. Whenever I'm eating the lens pieces, besides, the very last one, like in this case, obviously there's nothing left. But if in the early on cases, when I'm trying to eat pieces, I make sure that I'm emulsifying over existing lens pieces that are in the bag. So in this case, obviously, you have the final quadrant to remove. Very important that you use mechanical forces to crush the lens between the instruments, and keeping that chopper deep in the bag to protect the posterior capsule and reduce the risk for surge. Again, if you're using pulses of ultrasonic energy or vacuum, the chances of corneal wound burn are less, and the chances of post-occlusion surge are a lot less as well. There's a small fragment at the wound, a paracentesis wound, so I'm trying to grabbing it there. So I take the chopper out, but you can see I'm getting some ballooning of the conj right over that paracentesis incision. So I'm using the chopper to basically retract the conjunctiva there. Push some BSS in, take the phaco tip out, and then I go in with the ironing handpiece. So you can see, there's some lens material. It's just very wispy lens material that's left. Just going around circumferentially, grabbing any loose lens pieces, removing any cortical material as well. I switched to polish mode and polishing around as well. Again, I'm always concerned with these super dense lenses that the zonules are weak. And so the polish mode is really nice because it does help you assess the strength of the zonules without causing any traction or stress on the zonules because of the low flow setting. Use a BSS cannula to pulse into the subincisional capsule fornix. You can see there's some material coming out. I go after it with the ironing handpiece, still in polish mode. Filling the capsular bag with cohesive viscoelastic. You saw I did a quick maneuver to turn off irrigation by adjusting the INA tip. I go out just for a moment and I go back in, and it deactivates the continuous irrigation. You don't want irrigation on when you're pushing OVD into the eye, otherwise it causes OVD to come out. So you have to disengage continuous irrigation when you're pushing OVD in. So I'm sweeping with the sweeper, first on the left side and then the right side, removing all the lens epithelial cells under the rhexis edge. Also swept into the subincisional area, and it looked pretty clean here. This is a 3-piece lens. Again, with these dense lenses, I like to use 3-piece lenses, so I have to widen this incision. And obviously, it was still a little tight. And that's the only issue with this. You just have to widen the incision. You want to widen it enough to get the barrel in, but you don't want to widen it so much so that you have this really big incision. So just kind of titrate as I go, and then I'm cutting some more. All right, now I'm in. I turn the bevel towards the left. I push some more cohesive OVD because in the process of pushing the wound, it causes OVD to come out. I make sure the leading haptic goes underneath the rhexis edge. Turn my hand counterclockwise as the optic comes out to make sure it comes out flat. Making sure the trailing haptic comes out of the eye here. And then I'm using the Maltzman to dial the trailing haptic into the bag. All right, so now I got this nice 3-piece lens in the bag with both haptics into the bag. I go in with irrigation off, activating irrigation, and you want to go underneath the lens here very carefully. Since the wound is bigger, you can cause the continuous irrigation to turn off, so you have to be mindful of that. You want to have a nice formed chamber as you go underneath the lens. Start to remove all the viscoelastic from within the bag. Switch to polish mode, polishing underneath the rhexis edge. Switch to visco mode, removing all the viscoelastic from the anterior chamber. You can see all that ballooning of the conj coming from that paracentesis incision, which occurred kind of later in the case, towards the end during phaco, but luckily it's not really interfering at this end of the case here. And then I'll hydrate my incision. So again, this is a patient who had an intumescent dense Catarock. Instead of using the needle puncture and aspiration technique to decompress, I used my sharp tip Haldi Percars to puncture the center. I used the side of the forceps to kind of push and squeegee out any of that cortical milk from the bag. I also use a simultaneous OVD push where I'm pushing OVD to flatten the anterior capsule and keep the chamber nice and formed. Luckily in this situation, it worked out quite well. And again, this was a pretty dense lens. I went to terminal chop fairly early to help assess how dense it was. It was very dense. And again, I was able to conquer the posterior plate with terminal chop, but you saw with the adjacent pieces, when I started to fracture the heminuclei, there were some posterior adhesions. But no fear, no worries. I'm able to amputate and sever those posterior adhesions using the scissoring chop maneuver. Again, turning the chopper sideways and then amputating and cutting directly those adhesions. And you know you can do this because you first lift the lens piece up out of the bag. Therefore, that adhesion is away from the posterior capsule. I'm able to turn the chopper sideways with the scissoring chop maneuver. Again, it's away from the posterior capsule, and then I'm able to use that scissoring force to amputate the piece. Again, there's continuous irrigation on the entire time, so the posterior capsule is blowed all the way back, and the back is nice and distended. So I'm very confident I'm not near the posterior capsule. I'm not going to damage the posterior capsule, and the scissoring chop maneuver gives me exquisite confidence and control to amputate those posterior adhesions. So anytime you're dealing with a posterior plate, posterior adhesion, just know that you have to fracture the lens piece deep with terminal chop first, and then if you have any lens pieces, you can lift it up with some vacuum, and then that posterior adhesion, you can directly amputate it using the scissoring chop maneuver. So I hope this was helpful to you, and I thank you for your attention.